All right, good evening, everyone. I bring you warm greetings from Winnipeg, Canada. I hope everyone is well this evening and looking forward to a fast-paced hour of some good stuff that you can take to the office tomorrow morning. Special shout out to Daniel Souza Pinto Ramos and his colleagues in Brazil. Thank you for tuning in, and I really hope that we can give you some good ideas today for your practice. And of course, at the end, there'll be a chance for questions as well. So here we go. Really taking acceleration out for a spin these days, if you'll excuse the pun. And pretty excited about it. And I wanted to spend the next hour sharing with you this journey. I am a key opinion leader with Propel Orthodontics. And for speaking with you this evening, I will be compensated. And this presentation has also been approved for continuing education credits. So who am I? I'm a diplomate of the American Board of Orthodontics and a fellow of the Royal College of Dentists of Canada, a fellow of the Pierre Fauchard Honorary Dental Academy. I'm a member of Mensa. I'm still trying to hold on to as many brain cells as I can. Former assistant professor at the University of Manitoba Graduate Orthodontics program, and an Invisalign pioneer since about '98, an elite provider and an educator for Invisalign, and I'm also an educator for Henry Schein Orthodontics, and of course a key opinion leader and educator for Propel Orthodontics, which is the reason I'm speaking with you this evening. I have two offices, one in Winnipeg, Manitoba, Canada, and the other on the west shore of Lake Superior in Thunder Bay, Ontario, Canada. And that second office is Invisalign only. And so I'm really pushing myself to do lots more these days with clear aligners. And I like to go fast, be it cars or orthodontic cases. I like to see them go smoothly and quickly, elegantly, and to finish incredibly well. And I love technology as well. So those are the two reasons why I'm speaking with you this evening. So we've been working with the Propel devices now since pretty well the end of 2013, and really have some neat ideas under our belt here with both micro-osteoperforation and high-frequency vibration, and also the synergy between the two. And I've learned a fair bit along the way, so I wanted to update you on the latest thinking and encourage you as well, if you get a chance, to get a hold of this textbook. It's actually a pretty easy read with some wonderful illustrations, and of course it's edited by sort of the godfather of all of this research, Manny Alicani. And I learned a lot, actually. I thought I pretty well knew just about everything about the science behind how we're accelerating orthodontics, but I learned a ton from this book and have actually been able to put it into clinical practice as well. So I encourage you to have a look at this, such things as, closing very large spaces, and he talks a lot about the anabolic and catabolic effects of micro-osteoperforation, and kind of neat, actually. So if you need a summertime read, highly recommend this textbook. And of course, we have the three devices these days that are commonly used for micro-osteoperforation. The single-use device, and the one that I use the most of, which is the one with the reusable handle. And it actually has two tip options, one with a sheath around it and one without a sheath. And then more and more, we're using the power driver, and I'm enjoying its use, especially for cases where we're doing a lot of perforations. It's a lot easier on your hands, and we've got it down to a science now with an assistant working with me going forward and reverse as we go in and out of the perforations. So the three devices are now widely available and commonly used, and very effective. So a lot of you have seen this slide before. The 3 easy steps: we basically evaluate the treatment area, palpate the tissue, We generally want to stay in attached gingiva, but not always. And I'll show you certain cases where we want to go much higher than attached gingiva so that we can have the effect right up near the ends of the roots. Nice little chlorhexidine rinse, 2 times for 1 minute each before you actually do the procedure. And then we anesthetize the patient. Some people are comfortable using strictly topical anesthetic. I'm much more comfortable with a little local infiltration. Really need not freeze them too profoundly, but it is kind of nice that that they're not feeling too much at all when you're going after the perforations. Post-treatment, we have a little instruction sheet that includes advice on keeping things clean. They follow up with the rinses. We ask them to not take any anti-inflammatories. And it makes sense because actually for this to be effective, we want to encourage some local inflammation. So it's Tylenol instead of Advil generally. And the effect lasts for about 10 to 12 weeks and has this halo of influence of 8 to 10 millimeters. So, you know, we do most of our perforations from the buccal and the labial aspect, but we can still be assured that the effect will be beyond the buccal and into the lingual area in most areas of the mouth, so that we don't necessarily have to go in through the palate. Sometimes we do, though, and in particular I think of impacted canines and how helpful it is with those sorts of cases. So it's quite routine in my office these days for this to be used for acceleration, for braces, and in particular, sometimes we get teeth in a certain position, and we really want to move things along. So let the patient know that we want to perform some osteoperforation. We use words like we want to put little dimples in the bone and around the tooth, around that troublesome tooth, and it's going to soften the bone temporarily, and it's going to make that tooth turn much faster than it would have had we not used this technique. And patients are usually all for it. This is an adult, of course, and he's getting quite impatient because we brought this tooth in from a long way already. It was impacted. And so he wants to see it turn quickly. And so we went ahead and did the perforations. And in 12 weeks, we managed to get this kind of effect. The effect does last about 12 weeks altogether, after which you can feel free to repeat it. Or if you're happy with the positions of the teeth, of course, then we can just not call upon micro-osteoperforation again. So the other thing that we've been working with a lot lately is the high-frequency vibration device. Kind of neat. This particular device actually only requires 5 minutes of daily wear time, and it is of a higher frequency than some of the other devices that are on the market, and really it works well as an aligner seater, and we've been finding it sort of like the ultimate chewy. Basically, doesn't have to be bit on very hard, but the vibration for 5 minutes each evening really helps to seat those aligners and make them the most effective they can be. And we think that the combination of micro-osteoperforation followed by high-frequency vibration is pretty well going to be the holy grail of orthodontic acceleration. It looks as though they're going to have a nice synergistic effect. So it's the perforations followed by the vibration, and that's going to get you the most profound tooth movement in the shortest amount of time. And it's not just about the speed of the tooth movement, but it's also about the accuracy of the tooth movement, as in if you get those aligners to seat and the vibration follows up and keeps them seated, then obviously the teeth are going to move that much better. So very routine now that we use high frequency vibration. This young lady had a pretty complicated malocclusion, and this has been part of my journey with Invisalign, and it's been especially recently that I've been willing to take on cases like this with Invisalign. There was a time in my career where I sure wouldn't have thought of this as an Invisalign case, and I think the credit goes to the new plastic, the new attachments, and the software and all of the research and development that has gone into clear aligners have allowed us to be much more confident with really tough cases like this. But I'm going to want to feel assured that this is going to work. So especially, on that left side where I'm going to be sequentially distalizing teeth and then dropping that canine down, I want to make sure I've got all the possible helpers that I can. And in this case, it is actually high frequency vibration. So that's what the vibration looks like in the mouth. And you can see the attachments are on the teeth, and we're underway. We've been going with generally 1 week intervals with our aligners. And in certain cases, where we're doing micro-osteoperforation, we've been shortening the intervals to 3 days. But in this case, I'm going to go with the full week for each aligner and just make sure that they're seated with 5 minutes each evening of the high frequency vibration. The device is easy to use. It doesn't require any sort of different mouthpieces for different malocclusions like some of the other products do. Easy to clean, and it'll keep track of the patient's use as well for you. And it's rechargeable. So kind of a neat device, and patients kind of dig it. They seem to be feel more comfortable the day a new aligner goes in as well. So that's another neat thing. It tends to uptund pain a little bit the first night of a new aligner. So 12 aligners in, of course, we pull out our ClinCheck and see where we should be at 12 aligners at 12 weeks, of course. And we're pretty well spot on to what the ClinCheck has predicted and where we should be. So that makes me feel confident that that the aligners are being well seated, and I'm giving them the best chance to be effective with the high frequency vibration. So of course, that makes me think, well, why not combine micro-osteoperforation with high frequency vibration? And this guy is he's a really neat guy. He's kind of a tech fellow, and he said, Doc, let's do this as fast as you possibly can. Now, I'm aware that high frequency vibration hasn't been well researched with braces, but my own feelings about it are that it actually helps move teeth with braces as well. And we talk about it unbinding arch wires and stimulating extracellular activity. So he wants it all. So we said, look, we've got a pretty big space to close. Let's go ahead and use osteoperforation, and what the heck, we'll follow it up with vibration as well. So here's Grant, and neat guy. He's got a deep bite, and he's got a missing premolar on the upper right-hand side, and he wants all that space closed, and he wants it to be done in a hurry. As you can see, a lot of that I'm going to want to do fairly minimal anchorage, and so chances are, beyond my usual sort of space closing regimen, I'm going to consider using a temporary anchorage device here as well to kind of mesialize the posterior teeth. So away we go. Of course, he wants to use the white wires too, which are also troublesome because they're perhaps the most friction filled wires that we have. At first, we're just using power chains, and then we get actually into we're gonna close it with a temporary anchorage device. So we go ahead. You can see the perforations around the premolar and the molar, and then a month later, you can't see any evidence of the perforations, but you can see the teeth on the move. So at the 3-month point, we use another micro-osteoperforation as we add in the TAD. So whenever I think of TADs, I also think of micro-osteoperforation because it's usually the TAD is usually being used for something that's difficult, and also freezing them up anyway. And so the sort of 6 letters go together, and that is TAD, MOP, and we find that it's a really nice combination. One thing about the TADs, try not to perforate too close to them, because that sort of softening of the bone will also affect the bone that the TAD is in. So we kind of avoid that area a little bit so that we don't actually loosen the TAD. And sometimes we'll choose one size larger of the TAD as a method of not letting the MOP loosen it up. So here we are at 6 months with the TAD closing up and with the micro-osteoperforation, and Grant has been using vibration as well. In 7 months we hit him again. So we find that the effect lasts about 3 months altogether, and so every 3 months we've been using the micro-osteoperforation again. So in total, 7 months with micro-osteoperforation and high frequency vibration, and we're just about closed. So that's showing some really nice promise. And although it's not used, the vibration isn't particularly used for braces, we have been trying it out to see if it'll help out with that as well. So of course, in the aligner world, it makes a lot of sense that micro-osteoperforation and high-frequency vibration will really do the trick. And in particular, aligners and micro-osteoperforations are now kind of setting world speed records here for tooth movement. Here's a case, 51 days with 17 aligners and micro-osteoperforation, and it's done. So I know a lot of people say, well, you know, how do you deal with the financing on that sort of thing? Because it's so fast. But we usually try and talk these folks into, and we'll give them a pretty good incentive to pay all in advance, and then they forget about this sort of connection between the time and the money. Class 3 crowded case. This is the initial, and so we're going to use all of our guns with this one as well, as in micro-osteoperforation and high-frequency vibration. Some of these you'll find are the sort of pseudo class 3s where they have to posture their mandible forward to get their back teeth together. But in general, they work nicely with the aligners, class 3 elastics, and micro-osteoperforation around the tough teeth, in particular, usually the canines and the molars, and 3-day intervals with the aligners. All right, so I want to share with you a little video that I had made while I was actually doing micro-osteoperforation, and I'm hoping it'll really help you visualize how this is done, those of you that haven't done it or have only done it once or twice. And I'm hoping it'll make you feel more comfortable about it. So here goes. This is how to micro-osteoperforate. It's about 8 minutes long. Okay. Dense rinsing for 2 1-minute intervals. And please, yeah, this is round 2. Jen is an awesome rinser. We're going to want 3 rinses per day for the next 3 days, basically, and then the dimples will be gone by then. All right. And we're super lucky to have Barbie as our dental assistant today. So 18 aligners total, and you're about number 9 right now? Okay, and you were on 2-week intervals presently? Okay, want to speed that up? Yes, okay. Do you find by the end of the 2 weeks that they're feeling pretty passive and they're not doing much? Got it, okay, so after the 3rd day, not much else. Is there ever another episode, maybe at about a week and a half or so, where you feel a kick again, or not really? Okay, got it, got it.
All right. So with Dr. Reedhall's permission, after we've micro-osteoperforated you, we'd like to shorten you up to 3-day intervals, and let's make this happen. Okay? Yeah, is that okay? And we'll get you going on the vibration as well. 5 minutes per day for every day. Okay? Sing stop.
I hope so.
So we generally look for teeth that we know are going to be particularly troublesome. If we're going to 3-day aligner intervals, sometimes we kind of mop the whole mouth, but generally focus in on teeth that we know are going to be most difficult. And in Jen's case, it's likely going to be the lower incisors and also the lower molars as well. And yeah, so here we go. So watermelon better than pina colada. Note to self.
Watermelon tastes like Jolly Ranchers.
Jolly Ranch, okay, good to know, good to know. Awesome. And we generally prefer to go from the buccal. The exception would be, say, an impacted canine that we're trying to get mobilized, then we'll perforate on the palate. But if you recall that sort of diameter effect where it's 8 to 10 millimeters, you got to know that's in 3 dimensions. So it's going to go all the way around and onto the other side of the bone as well. Okay, so we got a little bit of anesthetic coming your way here. We generally want to avoid the mental foramen. So I'll sort of skip over and get to the anterior teeth. Prefer not to get into that area. So, so on the lower anteriors, as I mentioned, we generally find the need to only have one perforation between each root. Towards the back, generally 2 in a nice little column and at least 2 millimeters apart. Patients that are on a lot of anti-inflammatory, it doesn't work well with them. And in particular, for the next few days, if Jen does have some pain, we're going to ask her to not use non-steroidal anti-inflammatories such as Advil or Aleve, but instead choose something in the acetaminophen family, such as Tylenol. The idea is we actually want inflammation to occur, so that's a positive. And other patients we see trouble, and it's actually no matter how we're doing the orthodontics, is patients that are on bisphosphonates, as in osteoporosis patients where the drug is actually knocking out the osteoclast, so we're not getting the action that we want. I wouldn't use it in a pregnant person or anyone undergoing anything like radiotherapy or chemotherapy, of course. We would avoid it. But otherwise, it's pretty widely used, mostly in adults, of course. Kids, not as much needed, but in the kids, we use it mostly reactively when we run into teeth that just won't move. There we go. Okay. Any questions so far, you guys? Okay. So, of course, we'll just go around and make sure that she's not going to feel any of this. So this is the device here. And the removable part is this. So this is the disposable part. And this is the reusable part, which is autoclavable and can be used multiple times. This is disposed of as a sharp, of course. Generally, 1 mouth worth, so however many you're doing, and then it's disposed of. Some people say, can I save it? I'm going to do it again in 12 weeks, and the answer is no, you shouldn't do that. Yeah, so we take off its little protective cover, and you can see the sheath here, which has the graduations on it for the various depths. So as this thing goes in, the sheath retracts and exposes the screw. And as it hits the blue shell, that's how deep you're going. So it's 3, 5, 7 millimeters of perforation. Generally in the front, I'm going in 3. So that's actually accounts for 1.5 millimeters likely of soft tissue, and then another 1.5 millimeters to get through the cortical bone and into the cancellous bone. In the posterior, a little closer to 5 usually. And in the palate, closer to 7. Okay, so we're going to give this a go. And let me know if I'm bothering you or if you need a break. Okay. And you're sitting on your hands. It's good. Okay. You want to grab my tie? All right, so just sort of retract. You can actually have the patient close their mouth. This thing is pretty well straight on at 90 degrees, so we want to try and not irritate the commissure of their mouth. If she's a little frozen, she won't be able to tell you that. So let's start here, where we can really see it. So this is between the premolar and the molar here, and I'm going to go, as I mentioned, quite high to start. And so she'll feel it engage like that, and then we start turning it, and it's tidy ready, of course, so turned in a clockwise direction. Still okay? Mm-hmm. Yeah. And I'm putting pretty good pressure on it with my hand. You saw Dr. Shipley in the video. He was putting pressure with his thumb on the head of the handpiece as well. So there, I'm in 5 millimeters right there. Also to about 5 millimeters. And make sure we're all the way here. We're expanding here, so I actually want to go further back. You feel that at all? No, you're good? Okay, thank you. Either she's frozen or just being very brave for the camera at this moment. And you can actually feel it. You will feel when you're in soft tissue, you'll feel when you're in cortical bone, which is quite hard, and then you'll feel it go in to the cancellous bone, and it's much easier going. And you only need to be like a millimeter and a bit into the cancellous bone, and then it's going to do its thing. Okay, so a little tougher, and I'm actually pushing fairly hard here. And now I'm through. I can feel it. And you may be able to feel it a bit too, Jen. Yeah. Okay, so I'm going to stop there, back it out. So once again, it's just infiltration. We haven't blocked her, so she might feel it a tiny bit. So you can see the sheath is nice. There's a version of this without the little sheath on it. It's just an open screw, but I can't really tell how deep I am, or not as accurately anyway. It does not, no, you're right. And this one we don't want to go as deep. There's only a couple of millimeters worth here that you have to go in. And we want to get as close to 90 degrees as we can. That's why the handpiece is nice for the posteriors, because it has a contra angle on it, and it's a little less of a direct hit here. Still good? And, okay, no, I think we're done. Yay! Jenny, you are awesome. Awesome.
That makes me smile.
How was that experience?
Terrifying, but it was okay.
Okay. You did great. Thank you. All right? Good. Okay.
All right, so I hope that made things a little more clear on the actual how-to of micro-osteoperforation. And for sure, we'll save a little time at the end for some questions. But along the way, with all of this sort of acceleration going on, I've started to think a little bit beyond acceleration and how I can possibly use, especially micro-osteoperforation, to get me out of binds, literally. And it just kind of makes sense that now that it's so widely used and accepted for acceleration, how about if we look to getting to using the system to help us get out of tough places? And in particular, I mean teeth that just don't seem to want to move, or at least don't want to move very fast. And of course, that's contributing to decreased trust, decreased profitability, and decreased sort of fun that everyone's having. So if there's a way to sort of jumpstart some of these cases that are bogging down, I'm all for it. And in a lot of these cases, I'm using the system reactively and therefore really not charging for it, because I know the economics of getting myself out of trouble, saving my reputation, and saving my chair time. It's going to help in the big picture. So when we find that teeth are bogged down, almost in a lot of the cases, unless they've had an actual really bad accident or a partial avulsion, it's actually kind of unlikely that they're ankylosed. And in truth, what probably is more likely that there's just big ledges of bone impeding movement. There's just that they're bogged down. So the mechanism of micro-osteoperforation actually makes sense in these situations. And in particular, we talk about and to our patients, we talk about the MOP actually softening the bone. And we all know that that means that we're causing a localized area of inflammation. It causes our little cascade of cytokines, and which in turn recruits other cells that are useful for tooth moving. And as the osteoclasts start to resorb the bone, then of course the bone becomes less dense, and the teeth start moving again. So that's been an exciting little discovery. And in a lot of these cases, before I had this tool, the thoughts were either give up, perform a luxation, which was kind of a little more dangerous and possibly leading to avitality of the teeth, or sometimes even a segmental osteotomy, which has a lot more morbidity to it and a lot more expense as well. So I'm a little bit careful with informed consent when it comes to this. I run into one of these situations and I say, well, you know, we've had this technique. It's not absolutely proven that it's going to help, but it sure works well with acceleration. And we have the other alternatives of things like surgery or luxations. I want to give it a go, and almost always the patients will go, "Oh, geez, yes, let's try it." So without any sort of guarantees or anything like that, we go into it in that manner, and we talk about sort of climbing the ladder of invasiveness, and these devices much lower on the rungs of invasiveness than things like surgery and luxation. So when explained in that light, we often find that patients will absolutely go for it. So we use it with both braces and with the liners. And here's a few examples. So this is young Taylor. She's 15 years, 3 months old, terrific young lady. And she's got a malocclusion. She's come to see me. She's got a deep bite. And we had a look around, and we're not too clear on where her upper right canine is. That's actually her first premolar that you see in front of you. And sure enough, that canine is quite badly impacted. So we go ahead and do our thing and set her up with braces. We're going to open up some space for that eye tooth to come down. And we got into that setup that usually works quite well. And at about 16 months, we're in trouble. And what has happened is the canine is there, but it has become stuck. And of course, it acts like its own little temporary anchorage device and won't let the other teeth come down. Mm-hmm. So we go ahead with the micro-osteoperforation, and you can see that it was used around the canines and the teeth behind it, and not on the lower teeth because we want them to be the anchors. And then we're going to have Taylor work very hard with her rubber bands from here on in. So 4 weeks, we're seeing some hopeful signs here, and Taylor's been working hard with her elastics. She sees some improvement, and she's encouraged, so that's good. And then 4 months later, we're still not quite happy, and we realize that it's not just the canine that is stuck, it's also the lateral incisor. So I've moved my micro-osteoperforations further mesially, and once again, we'll encourage Taylor to really hit it with the rubber bands. And 2 months later, whew, we're out of the woods. So I credit the micro-osteoperforation with getting me out of a pretty tough bind here with Taylor, and getting back on track in a case that otherwise I probably would have sent to the surgeon. So with apologies to the surgeon, we had some success with Taylor. So in 6 months and 2 micro-osteoperforations, we got to there, and there's a deep sigh of relief from everyone involved in this case, for sure. And also, of course, we have been using it with difficult movements with aligners as well. And this is Desiree. She's 37 years old, and she has a large space that she would like closed. And of course, she wants clear aligners as well. And she doesn't want any other kind of auxiliaries and that sort of thing. She says, let's see what we can do with clear aligners. So here's Desiree. And it's a fairly large space that she's got to close, and I really want to see if we can do it with the aligners alone. So here's the setup. We get going with Invisalign. She also has some small upper lateral incisors, you can see. So we're going to intentionally leave space around those teeth for some later widening as well. You can see there's some perio concerns as well. We had the periodontist have a look at her and make sure that we weren't going to do any further damage. But I've actually had some nice success with these cases where we're using clear aligners and Propel, and we seem to at least not get worsening of the gingival attachment situation. And in some cases, we actually get them improving. And I think it's all about sort of de-stressing these teeth and getting them out of parafunction as well. So here's the clin check, and we're going to go ahead. She's got 39 aligners altogether, and away we go. So there's aligner number 1, and we're using micro-osteoperforation and high-frequency vibration. So you can see the MOPS are above the edentulous space and on either side of the molar as well. It's this. We want most of the space to close from the back forward. And so away we go. And she's using the vibration for 5 seconds, pardon me, 10 minutes. Let's try 5 minutes, sorry, after supper each day. And in 16 weeks, we had a look at the clin check, and then we had a look at her clinically as well. So you can see the gingival response is quite good. And it looks quite a bit like the clin check suggested it should. So really kind of neat, and we'll continue to watch this case. We're hoping for as close to bodily movement as we can of that molar. You can see it tipping a little bit. But one of the neat things about micro-osteoperforation is the way that it can be targeted to go up the root high enough to get to that magical center of resistance of the tooth, so we can get as close to bodily movement as is clinically possible. And then we had another young lady, and this one too, a little bit of my own ideas. This was Emerson, and she's 15 and a half, and she had an occlusal plane cant, and she has some teeth that just weren't coming down. So she was referred over to me by another orthodontist who wasn't using micro-osteoperforation. And the other part of her history is her mom went through all of this, and she ended up having a really tough time and ended up with a permanent cant because despite all the right things that were done with the technology that was available at the time, certain of her teeth just wouldn't erupt. So we had a good look around at Emerson. The previous orthodontist had used a lateral tongue crib, which was a good try for sure, in case that it was indeed a lateral tongue thrust that was as part of the etiology of these teeth not emerging. So you can see the little tongue crib there. And in the other 3 quadrants, besides the upper right, the teeth were actually behaving fairly well, a little bit slowly, but they were indeed emerging for Emerson. Upper right, not so much. And so you can see here on the pano that in the 3 quads, that looks like fairly decent eruption pattern. And then, of course, up here, not as optimistic. And Mom wanted us to be really careful because she knew of the consequences of tugging on teeth that were stuck and having the other teeth are adversely affected by that. So what I decided was I wasn't going to put any force on those teeth at first. And instead, I was simply going to use micro-osteoperforation. So we're in braces, and we've removed the lateral tongue crib, but we have not hooked on to these emerging teeth at all. So here we are, 1 month, and of course everything is healed up nicely. We find that the actual wounds from the micro-osteoperforation heal up really quickly, and very little evidence, even after 3 or 4 days, of what has been done. But we know from the research that that the effect is still good for about 12 weeks. And you can see this was around Christmas time, 2016. So 2 months, and everyone's starting to get kind of optimistic about all of this. So you can see we're into a rectangular wire on the lower, still not hooking onto these teeth, but very much cheering for them to come down. And so 3 months, I knew that the effect was going to be wearing out at this moment. So approached Mom and said, okay, I want to put some brackets on these teeth, but let's perforate her again. And then we're going to be sure that we'll keep this this train rolling that's allowing these teeth to emerge. So in 4 months, we're there. And of course, this case is still in progress, but she's coming along nicely. And with those upper right teeth are coming down, finally, to everyone's relief. So 4 months and 2 MOPs we got from there to there with Emerson. And so you've probably seen this in your clinical experience and kind of at a loss of what to do. Sometimes we go in and luxate these teeth, or we kind of give up on them. But this is a really neat alternative, not too invasive, and it's showing some promise of effectiveness for these cases. So here's another one with aligners, and I think the movement that is the most challenging in my hands nowadays with aligners is widening in adults. So the transverse dimension in an adult, especially in these sort of unilateral cross bites, I've just been finding that the aligners themselves don't seem to have the horsepower that we need. And so we really want to have some extra help. Of course, a lot of these patients have actually either been through orthodontics before or are older and they really don't want to wear braces. So Susan said, hey, let's see what we can do with the aligners. And I said, okay, but you got to let me try something else as well. You've got to let me do the micro-osteoperforation. This was an Invisalign Assist case. We use a lot of Invisalign Assist, but we ask that we don't get advice or progress tracking, and that gives us a little discount on the fees. So I like the sort of 13 aligner treatment, but don't want advice and tracking. So Invisalign gives us a little discount on these cases, and they still count towards your status with Invisalign. So 2-week intervals in this case. I really want I still like to be the gatekeeper of the intervals. We do a lot of 1 week, of course, and but in a lot of cases we do 2 weeks where the case is going to be particularly tough, or we know the patient and we just know that they're not going to be super compliant. I got one lady on 3-week intervals as well. And we have, of course, we have some on the 3-day intervals as well also. So wide range, and I still like to be the gatekeeper of the intervals. Sometimes we'll start out long, and then for good behavior and good tracking, we'll say to them, oh, okay, the teeth are all limbered up now, and we've done the perforations. Let's shorten the intervals, and that's great. Much better than the other way around, where you've gone to 1 week or 3-day intervals and it just isn't working. Then you have to extend the intervals. That's kind of backwards. So I like to start out a little long and then shorten it up for good behavior or good tracking. So here's Susan. She's actually had orthodontics before. She's had jaw surgery before as well. And a super lady. And of course, we see some of the unfortunate gingival things that happen in these cross bites. And we're really motivated to get her wider on that upper right-hand side and see if we can get things fitting a lot better. So there she is to begin. You can see the fixation plate. She actually has a little screw that came undone, and it's sort of asked her to shake her head, and couldn't hear it, but it is definitely loose. So she had a Laporte osteotomy, and she has since relapsed into full crossbite on the right side. And of course doesn't want surgery again. So she goes, "Doc, let's just do whatever you got, and let's see if we can get some of that width again." So here we are underway with the liners. Right away we perform the micro-osteoperforation right from aligner number 1, and we follow it up with the high frequency vibration. So she'll be using this for 10 minutes each evening, or pardon me, for 5 minutes each evening after supper. I'm having trouble with that. So here's the clin check, and we're going to, we ask for over correction on these ones, as in about, we say to the ideal and then 2 millimeters more. So everything is kind of over-engineered with our clin checks. And then we, because we see clinically that things come up short compared to what we see in clin checks. So 13 aligners, and we're going to ask for about 2 extra millimeters of buccal overjet, knowing that we're just not going to get it. The other thing that we watch for is buccal root torque as well. And for this, you can actually change the background of your clin check to a darker color. It's up in the settings, and it actually helps you to see the lingual cusps a little bit better and tell if you've got the appropriate amount of buccal root torque when you're doing this. So darken the background, have a look at these cases from the side, and you'll be able to see if you've got appropriate buccal root torque and therefore not those hanging down cusps on the palatal. So we're underway. First set of aligners and the micro-osteoperforations. You can see that they are around the first premolar, second premolars, and molars, and we're trying to go up fairly high with these because I want to be affecting the root of the teeth and not just sort of in the attached gingiva. Some people have mentioned they have a little bit of trouble with unattached gingiva, but a few techniques that we use, we sort of use our finger and thumb to stretch out the tissue a little bit before you do the micro-osteoperforation. The handpiece is a little bit more troublesome when it comes to winding soft tissue around its burr. So sometimes we'll back off and use the handheld, the manual driver in those cases. And sometimes it's easier with the manual driver with the sheath on it because it doesn't seem to wrap the tissue as much. So if you're up high in alveolar mucosa and you're having trouble with winding tissue, maybe back off to the manual driver and use the one with the little sheath on it. So away we go, 1 month. Once again, no evidence whatsoever of where the perforations are. And Susan is extremely compliant. She's terrific. 2 months, here we go. You can see the teeth starting to get over and into the correct buccal configuration. And here we are at 4 months. Now we're, of course, at the end of our aligners, are getting close to that. So we are going to case refine her, as in scan her again. And even though we asked for the overcorrection, of course, we're not quite getting it. So we just asked for more overcorrection. And we're going to do some more micro-osteoperforation as well. So that's where we are with Susan right now. We're getting out into the second round of aligners, and we'll just continue with our vibration and the micro-osteoperforations. And once again, I'll have you just notice the gingival response, and it is at least not any worse. And we sure like that about the aligners and the micro-osteoperforation and vibration. It seems to be very gum friendly. So here we go. We're rebooting her and remopping her, and we're not quite finished this case, but stay tuned. We're determined to get her out into full buccal overjet. So what I'd like you to think about from our little time together is that acceleration with micro-osteoperforation, very routine now and well proven, scientifically backed up in referee journals and now in a textbook as well. And I encourage you to learn about it and try it out. And I think you'll be amazed. I continue to be amazed, even though I've used it for a long time now. High frequency vibration also is showing some synergistic effect with the micro-osteoperforation. And I think eventually the two of them are going to be recognized as the gold standard for orthodontic acceleration. And the next frontier, therefore, in my mind, is utilizing MOP and high-frequency vibration to make tough movements less tough. And that could ultimately result in less surgery, less luxations, less complications, and less expense, and happier patients. So that's what we're all about. And ladies and gentlemen, it's been a delight hanging out with you this evening. And I'll absolutely stick around and answer any questions, and I'll read them out before so you can all participate in this. Thanks. Gosh, I did such a good job. Nobody has any questions. That's amazing. All right, so if nothing else comes to mind, we're going to wrap this up. And if you have anything further, you can really, a great way to get a hold of me, you'll see the website below. It's called I Can Do, and it's my little website for helping out dentists in orthodontics. And the questions can come via through Carla at info@icando.ca. Make sure it's .ca. It's a Canadian site. So info@icando.ca. And if anything, pops into your mind. And ladies and gentlemen, otherwise, I wish you a fond farewell and a great evening. And thanks again for joining me for this webinar. Bye for now.